The last cardiac lecture I will be giving you would be on the pathology of valves or valvular heart disease. The non-medical pictures pertaining to this lecture come from Myanmar, previously known as Burma. This is one very beautiful area in the Bagan Plains of Myanmar, which is up northern part of the country, mid-north, where you have this very large plain, like the Bika Valley, if you will, and they have about 4,000 pagodas or temples of worship throughout the plain and nothing else. So every family comes and builds their own pagoda for prayer. It's also very beautiful to go over this on a hot air balloon. We're going to go over the common valvular diseases and understand their pathogenesis. One of the more common in our population here in Lebanon is rheumatic fever and rheumatic heart disease. Degenerative calcific aortic stenosis is the most common valvular disease worldwide. Mitral valve prolapse and infective endocarditis, both acute and chronic. The normal valve is paper thin, and its function is to prevent regurgitation, so to prevent backward flow of blood. This is looking at the heart from the top, and you have the four valves in their anatomic location. The most anterior valve is the pulmonary valve. Behind it lies the aortic valve. To the right-hand side is the tricuspid valve, and to the left, the mitral valve. These two are called semilunar valves because their shape is like a semi-lune. And these are the atrioventricular valves because they control blood flow between the atrium and the ventricle. Histologically, here is a valve leaflet. It's covered by endothelium and contains in its center a connective tissue. The one towards where the leaflet opens, because this one will open downward, is more dense connective tissue, while the connective tissue on the surface is more loose. And blood oxygenation occurs by direct infusion from the chambers. There's no blood vessels that go into the leaflets. Here is a semilunar valve. It could be the atrial, the aortic, or the pulmonary valve, and you can see the three leaflets whose function is to close the orifice of the valve so that blood doesn't regurgitate downward. Of course, it also opens, so these leaflets open and close, but the main function is its closure. The atrioventricular valves look quite different. They have this thin, paper-thin membrane, which is actually the valve leaflet, which are held by corda tendineae or thin fibrous bands to the papillary muscle. So this valve opens and closes to prevent regurgitation. When a valve is dysfunctional, it either functionally becomes stenotic, which means that it doesn't open completely, so there is impediment of forward flow. Stenosis, the valve doesn't open properly. Regurgitation or insufficiency is when the valve fails to close completely, so there is reversal of flow. And usually when a valve is abnormal, it is both stenotic and regurgitant at the same time to different degrees, but this is not always the case. And when you have a defective valve, it results in murmurs. You hear the blood going back and forth through an abnormal or dysfunctional valve. Valvular stenosis, when the valve doesn't open completely, is always a disease of the cusp, okay, يعني of the leaflet. It's always a chronic affair, and it results in pressure overload. So the chamber that is trying to push the blood out through the defective valve is going to be working at a high pressure to push the blood out of the stenotic valve. Here we're looking at a semilunar valve where the leaflets are fused and fibrotic, so this valve doesn't open completely. So the chamber behind it, which in this particular case is the left ventricle, is going to be pushing the blood out of the stenotic orifice, so there's going to be a pressure overload. So the heart is going to dilate and hypertrophy. The chamber that's facing this stenosis. Valvular insufficiency, on the other hand, yani regurgitation, where you have abnormality in the backward flow, can be a disease of the cusp or the supporting structures, yani a papillary muscle or the heart itself, and you'll see an example. Valvular insufficiency can be due to both acute or chronic ailments. And here we have a volume overload. So the blood goes back and forth, and we'll see how this happens. This is the same valve we saw a minute ago. It's a semilunar valve with fusion and fibrotic thickening of the leaflets. Now, as we just said before, this valve doesn't open completely, so it is stenotic, but it is also regurgitant because the leaflets don't close properly. So when the blood comes out, it's going to go right back in, right? So this valve is chronically disordered, right? It's a disease of the cusp, and there is a volume overload because the blood goes out and goes right back in when we're thinking about the regurgitation. Here is a picture of the left ventricle with an aneurysm secondary to myocardial infarct. And imagine the mitral valve as it is dilating and being pushed open by this aneurysm, right? So the leaflets of the mitral valve, in this, which we can't see but you can imagine, open normally, but they don't close properly because of the dilatation, so there's going to be a regurgitation. So mitral valve regurgitation, it's a chronic ailment here due to the aneurysm, but the leaflets are fine, but it's the supporting structure of the mitral valve that has dilated, resulting in regurgitation. In this example, we're looking at the mitral valve with a ruptured papillary muscle. This particular patient had a myocardial infarct, and at around day 4 or 5, when the heart muscle is very soft, the papillary muscle ruptures. What is a mitral valve going to experience? Is it going to be stenotic or regurgitant? It's going to be not stenotic because it can open normally, there's no problem, but when it wants to close, instead of the muscle and chordae tendineae holding the leaflet in place, the leaflet is going to just flop into the atrium, and there will be a regurgitation. So this is an example of an acute regurgitation resulting from a supporting structure of the valve. So you can see how regurgitation of valvular regurgitation can be acute, can be chronic, can be due to the leaflet or the supporting structures. Here is another example of an acute regurgitation resulting from, where are we here? We're in the semilunar valves. You can see the 3 valves here. We're not looking at them from the top, we're looking at them from the side. And here are the coronary ostia, or the opening of the coronary arteries. So we're in the aortic valve with infective endocarditis, which resulted in perforation of the valve leaflet. Now, if you think of this leaflet with a hole in it, is the valve going to be stenotic or regurgitant or both? And is it an acute or chronic process? Well, It's not going to be stenotic because the leaflets can open perfectly fine, but when they're supposed to close, you have this hole here and blood is going to regurgitate backward, and it's an acute process of the abnormal leaflet. Now, the clinical consequences of valvular dysfunction depends on which valve is involved, the degree of impairment, how fast the impairment occurred, and whether the heart has had time for compensatory mechanisms. The first entity that we're going to discuss is rheumatic fever and rheumatic heart disease. There are three events that define this condition. The first one is a pharyngitis with group A beta hemolytic strep, followed by a systemic illness called acute rheumatic fever, which would include within it acute rheumatic heart disease. And following multiple attacks of acute rheumatic fever, the heart goes into chronic rheumatic heart disease. So we have a bug, an organism, which attacks the oropharynx, the tonsillar area. An immune response occurs, resulting in this second problem, and then many years later, chronic rheumatic heart disease. So what is the time span between these different conditions? The pharyngitis, the acute rheumatic fever, and chronic rheumatic heart disease. The pharyngitis usually occurs in children, and within 1 to 5 weeks after the pharyngitis, there is an antigen-antibody reaction and resulting in this acute rheumatic fever. So let's say the pharyngitis occurs today, 1 to 5 weeks later, the patient will have acute rheumatic fever, and then 10 to 20 to 30 years later, chronic rheumatic heart disease expresses itself. The pharyngitis occurs in children, and it is due to one organism, which is group A beta hemolytic strep. 3% of children with group A beta hemolytic strep pharyngitis are going to get acute rheumatic fever. So it's not all patients, it's a small percentage of patients with this organism. This particular organism has a hyaluronate capsule which is identical or very similar to human hyaluronate. So the body mounts an immune response against the capsule of the organism. So the antibodies are formed against the organism, but instead of reacting with the organism, it also reacts with the normal hyaluronate within the normal tissue. So there is an antigen-antibody reaction, which is a sterile, useless, harmful antigen-antibody reaction. It's resulting in a sterile inflammation. So the antibodies that are formed to attack the organism actually attack our own bodies and result in these inflammatory foci, which are sterile because it's just antigen-antibody reaction, and these inflammatory bodies these inflammatory foci are called Aschoff bodies, and you find them all over the body. So here is the sequence of events that occurs in rheumatic fever. The child with group A beta hemolytic strep, the organism is in the throat. The body, it takes it 1 to 5 weeks to mount an antibody response to the organism. These antibodies cross-react with normal human tissues and give you sterile inflammatory foci in all of the body. But since we're talking about the heart, we're going to focus on the heart. So you have inflammation of all layers of the heart. The pericardium giving you a pericarditis, the myocardium giving you a myocarditis, and an inflammation of the valves, which gives you a valvulitis, if you will. So all layers of the heart are. So the inflammation is systemic, resulting in fever. The heart is affected, the joints, the central nervous system, the skin, everywhere you have these inflammatory foci. In the heart, there is a pancarditis, an endocarditis, which is affection of the valve leaflets, the myocarditis, which is inflammation of the myocardium, and the pericarditis, which is inflammation of the outer surface of the heart. The acute attack resolves usually, leaving behind damaged cardiac valves. The Aschoff body is what we see in acute rheumatic fever. It is the sterile, microscopic inflammatory foci. They're small, only seen under the microscope, and you see them in acute rheumatic fever. You see them everywhere, including the 3 layers of the heart. So the same lesion you see in the brain, you see in the skin, the joints, and so on. These microscopic inflammatory foci heal by making a little scar, wherever that may be. So you'll have scars in the brain, scars in the joints, scars in the myocardium, and scars of the leaflets. So this is a high power view of an Aschoff body, which is just a microscopic focus of inflammatory cells, including some lymphocytes, some plasma cells, and these macrophages, which are particular to the Aschoff body. And notice it's a tiny little focus of inflammation. After the inflammation resolves, you're left with a little fibrous scar. The inflammation in the pericardium resolves usually without a problem. So you have little fibrotic areas within the pericardium, but it's of no clinical consequence. The myocarditis, or the inflammation in the myocardium, can result in a cardiomyopathy, meaning decreased pumping activity of the heart, but this is usually transient and resolves without consequences. The only important consequence of the myocarditis is the possibility of fatal arrhythmias. This occurs in 1% of patients. They're rare. It occurs during the acute attack of rheumatic fever, but luckily it's a rare occurrence. So these little inflammatory foci in the myocardium result in tiny scars that really don't affect the heart in any particular way. Now, in contradistinction, the inflammation of the valves is much more serious. Why? Because the valve leaflets are very thin and delicate structures. When they are involved by the inflammation and heal by fibrosis, these very thin leaflets become fused together because of the fibrosis, and they become thick. So the thin, delicate valves heal with fibrosis. With repeated attacks of group A beta hemolytic strep, a second attack of acute rheumatic fever, more inflammation in the leaflet of the valves, more fibrosis, more fusion, this results in a deformed, dysfunctional valve, and this is what becomes problematic. So the inflammation of the pericardium is of little consequence. The inflammation of the myocardium is of little consequence except for the arrhythmia, but the inflammation in these very thin, delicate leaflets is what causes clinical problems many years later. So chronic rheumatic heart disease occurs 10, 20, 30 years after a child who's had multiple attacks of acute rheumatic fever. The valve leaflets are deformed and the heart starts to decompensate. Here we're looking at a diseased mitral valve. You can note that the leaflet is no longer transparent or paper thin as we had seen earlier, and the chorda tendineae are also thickened and shortened because of the fibrosis. Here is the same mitral valve. Looking at it from the top, you can see that the leaflets are fused and thick. So this valve neither opens completely because of the fusion and the thickening, nor does it close completely. So it is both stenotic and regurgitant. This is the aortic valve of the same patient. We had seen it before. Notice that the leaflets are very thick and they're fused. The only disease that gives you this is rheumatic heart disease. So in chronic rheumatic heart disease, the valves are deformed due to recurrent attacks of acute rheumatic fever. The leaflets are thickened. There is fusion of the commissures, meaning the leaflets fused together, and you don't no longer have 2 or 3 leaflets, but it's one fused leaflet. The chorda tendineae are thickened and shortened by the repeated inflammation and fibrosis. Also, calcifications tend to occur on these valves. The valves look like a fish mouth or a buttonhole, as we have seen. I guess this is the most important concept in chronic rheumatic heart disease. So despite the damaged valves of the heart, which have happened when the child is early childhood and teenagery, the heart is able to compensate for years by hypertrophy and dilatation until a point where it decompensates. So the damage is done early on, but the heart compensates and compensates and compensates, and then at one point, 10, 20, 30 years later, it'll express itself as chronic rheumatic heart disease. So these chronic changes express themselves at least 10 years after the acute rheumatic heart disease. Because of cardiac hypertrophy and dilatation, the patient can suffer from congestive heart failure, from arrhythmias, particularly atrial fibrillation, from thromboembolic phenomenon, which we'll see how, and infective carditis, and also will have murmurs, which are not of clinical consequence, but that's how you can detect them. Here we're looking at the mitral valve from the top. So this is the left atrium. Here is the mitral valve. Looking at, can you see that the leaflets are completely fused? The opening looks like a fish mouth or a buttonhole. Does this valve open completely? No. Does it close completely? No. So this is chronic rheumatic heart disease. Why does it take decades for clinical symptoms of chronic rheumatic heart disease to develop? Because the heart has its compensatory mechanisms, which keeps the patient out of trouble for quite a while. Do we see Aschoff bodies in chronic rheumatic heart disease? The answer is no. Aschoff bodies we see only in the acute stage, and in chronic rheumatic heart disease we just have the fibrosis. This has occurred years before. In this condition, the valves affected are those of the left side of the heart. The mitral valve alone is affected in the majority of cases, and the rest will have mitral valve plus aortic valve involvement. So mostly the mitral, followed by both mitral and aortic. The right-sided valves are rarely affected. And rheumatic heart disease is basically the only disease that causes mitral valve stenosis, whereas aortic stenosis can occur by other conditions. What is the treatment for rheumatic heart disease? Most important is prevention. So if a patient has group A beta hemolytic strep and then has acute rheumatic fever, then that patient is placed on prophylactic long-term antibiotics so that a repeat repeat group A beta hemolytic strep infection doesn't occur to prevent recurrent rheumatic fever. So not everybody with this organism is treated, only those who have acute rheumatic fever. And this is the best way to prevent rheumatic heart disease. Now, once patients like here in Lebanon, who haven't had this treatment when they were young, present with chronic rheumatic heart disease with the abnormal valves, then surgery is the mainstay of treatment. Here we're looking at the left ventricle that's open. This is the aortic valve, the semilunar valves, and here is a prosthetic valve which has replaced the mitral valve which was defective. The next valvular disease that we're going to cover, and the word says it all, the name of it, degenerative calcific aortic stenosis, is a common valvular disease, if not the most common, and that's why it's important to be aware of it. And this is a degenerative condition occurring with age. In elderly patients, they start to get calcium deposition at the base of the aortic valve leaflets. You can see here these nodular calcifications at the base of the leaflets. The leaflets are not fused because there's no inflammatory process going on, but you have this rather bulky calcification. Now, this calcification causes stenosis of the valve in that it doesn't open properly, but is not a regurgitant valve. So there will be pressure overload in the left ventricle. As we said, it is the most common valvular abnormality. The calcification occurs on normal valve, and it is induced by wear and tear and presents in the 8th and 9th decade of life. Now, there is a congenital bicuspid valve, meaning that the aortic valve, instead of having 3 leaflets, has 2 leaflets. And this is a relatively common malformation, 1% of the population. In these patients, the calcification occurs earlier and the patient will present with aortic stenosis at an earlier age. So the calcium is at the base, resulting in stenosis of the valve, and it accounts for the majority of aortic stenosis, right? The other condition that causes aortic stenosis we just went over is chronic rheumatic heart disease. So how are we going to tell the difference between the two? Can you tell by looking at this picture whether this is degenerative calcification or rheumatic heart disease? Well, the leaflets are not fused and the calcium is at the base, so this goes for degenerative calcification. Here is a bicuspid aortic valve. You see that you have just 2 leaflets instead of the 3. The calcium is at the base. The valves are not fused. This is a bicuspid aortic valve with earlier calcification. Again, we're in the aortic valve. What's wrong with this one here? Here they're fused, they're thickened, and the calcification is not that prominent. This is rheumatic heart disease. And usually when the aortic valve is involved, the mitral valve is also involved. The next disease is mitral valve prolapse. Again, everything is in the name. This is a cartoon of the normal mitral valve. When it closes, the leaflets sort of are held together by the chorda tendineae and the papillary muscle so that they don't bulge out into the left atrium, and there's complete closure preventing regurgitation. In mitral valve prolapse, the connective tissue of the chorda tendineae and of the leaflets is loose. It's more myxoid. It's not as tense. So when the leaflet closes, this loose connective tissue allows the leaflet to open, and there is regurgitation of blood from the left ventricle to the left atrium. Now, if you go back and forth between the two pictures here, you can actually make a little video of mitral valve prolapse. Let me see if I can do it. So I can't do it, but if you go back and forth between those two images, you can see how when the heart is pumping, how the blood seeps back into the left atrium with every stroke. Now, mitral valve prolapse results from myxomatous degeneration of the mitral valve with elongation and thinning of the chorda tendineae. The mitral valve balloons into the left atrium during systole. It's a common abnormality, mostly in females, accounts for 3% of the population who have it, but generally it's of little clinical consequence, usually asymptomatic. This is a lady in Myanmar from a particular tribe that believe that their long necks is a very beautiful female attribute. So when they're children, they increase these rings gradually until the neck becomes quite long. But you know, when they take off these rings, the head just flops. The last entity we're going to discuss is infective endocarditis. Again, it's all in the name. Infection of the endocardium by bugs. Here is an example of, let me get my pointer, of infective endocarditis. Again, what valve are we in here? This is the aortic valve with the coronary ostia in the background, and you can see this vegetations, which are these granular structures sitting on the valve, actually here causing perforation of the valve, caused by bacterial organisms, inflammatory cells, adherent thrombus, and so on. It is caused by colonization of the cardiac valves by microorganisms, usually bacteria, but it could be fungal or even parasitic, but usually they're bacterial organisms, and they result in these vegetations that I showed you on the previous slide, that are composed of the multiplying bacterial organisms, the inflammatory cells as the inflammatory response, necrotic material, and thrombus formation because of the disrupted endothelium of the valve. So it makes this conglomeration of organisms, inflammation, thrombus, and necrosis. Here's another example of vegetations on the mitral valve this time, and you can see multiple, numerous small vegetation sitting on the leaflet. Pathogenesis comes from seeding of the blood with microbes that adhere to the cardiac valves. Conceptually, we divide infective endocarditis into acute and subacute forms, which have different pathogenesis. We're going to start with the acute. In the acute form, the valve and the patient are usually normal. So a virulent organism enters the bloodstream. Usually it's Staph aureus. This organism comes in either via IV drug abuse, dental work, surgical procedures, and such. So the staph adheres to the valve, forming a large vegetation which may cause perforation of the valve. And when it perforates, what do we get? Stenosis, regurgitation, acute, chronic, we get an acute regurgitation. The clinical onset is acute, the mortality rate is high, and the treatment is IV antibiotics and possible surgical intervention and removal of that diseased valve. Here is an example of acute endocarditis. The valve is normal except for where the vegetation is. So here you have a virulent organism that colonizes this normal valve, multiplies, divides, and causes an inflammatory response, and you can see here the perforation that it has caused. This is the same picture from the first case that I showed you. Again, the leaflet away from the vegetation is normal. The vegetation is large, it's aggressive, it causes perforation sometimes, and these are bulky vegetations from acute endocarditis. The subacute form comes from a valve that is already abnormal, either due to rheumatic heart disease, congenital heart disease, or other other causes of valvular abnormality. As the blood goes back and forth through the abnormal valve, it causes injury to the endothelium of the valve because of mechanical stress, and platelets adhere to this subendothelial collagen, forming initially sterile thrombi on the valve. These are microscopic thrombi. These thrombi are a good milieu for organisms to adhere. So normally in our bloodstream we have low virulent organisms, especially strep viridans, that normally circulates in our circulation. And these organisms now adhere to and find a nice nidus in the thrombi that were formed up here, and they divide relatively slowly, give you a subacute protracted clinical course, and most patients recover. So this is an example of subacute endocarditis occurring on a patient who already has mitral stenosis from rheumatic heart disease. So as the blood goes back and forth through this fish mouth valve, if you will, it causes breaks of the endothelium, initially sterile thrombus followed by infective endocarditis by strep viridans. The most serious complication of endocarditis is sepsis, excuse me, I'm getting my pointer here, because the vegetation is a source of bacteria that keeps feeding the bloodstream. So sepsis with either virulent or less virulent organisms is a major complication. Other feared complications are valvular insufficiency, which occurs when a valve is perforated, and usually this occurs in acute endocarditis with acute onset of regurgitation. The inflammation in the valve may erode into the myocardium, resulting in a myocardial abscess or a pericarditis. Embolic complications is when a fragment of this vegetation breaks off from the valve and travels through the systemic circulation if the vegetation is on the left side of the heart, which is a more common occurrence, resulting in septic emboli because it's a thrombus also carrying with it the bacteria. So the septic emboli can be seen usually in the peripheral extremities, causing microinfarcts with inflammatory reaction and infection with the same organism that came from the valve, also in the mucous membranes of the mouth and eyes, etc. That concludes our lecture on valvular pathology. I wanted to show you a few more pictures from Myanmar. There is this lake called Inle Lake where the villages and people completely live on the lake. They don't have any ground that they live on. The houses are built on stilts. They go around, instead of having cars, they have boats, and they even plant their vegetables in the lake, and I'll show you a picture. This is their usual mode of transportation in these little boats. They do their shopping, they go visiting, and there's no land to put your feet on. And these are their vegetable gardens, which are called floating gardens. They get roots from the bottom of the lake, fill them with soil, and make these like landfills, if you will, but they're floating. They don't reach the bottom. And on this dirt, they plant their tomatoes, their cucumbers, and so on. And they go around in their boats and pick their vegetables. Very interesting community.